Hello and good evening. My name is Ragnar Peterson. I am a general surgeon in Wichita, Kansas. And we are all members of the Quality Improvement Committee, and we put together a few talks today for you in regard to preoperative rehabilitation and rehabilitation and using our website and the apps. And so thank you for joining us. At this point, I'd like to introduce my co-moderator, Ron Lewis. He's from Gainesville, Georgia, and he's a private practice surgeon.
I appreciate the opportunity to be with y'all tonight and glad everyone could join. Our first talk this evening is going to be delivered by Dr. Winnie Henderson. She is a private practice surgeon outside of Eugene, Oregon. If my Google Maps skills are as good as I think they are. And she is going to be presenting on incorporating abdominal core surgery rehabilitation protocol and the ACHQC mobile app into your practice, a private practice surgeon perspective. Dr. Henderson.
Thank you for the opportunity to present today. I'm going to start sharing my screen. Are you able to see my screen? Okay. So as Ron mentioned, that I'm a private practice surgeon in Oregon. As private practice surgeon, we don't usually have a lot of resources. So we really depend on outside resources, and being part of the ACHQC allowed me to actually discover a whole world of knowledge and resources that you know, I myself would not be able to put together. So, so I frequent the website and I discover over time all these resources that I can incorporate into my hernia practice. So today I'm going to talk about how to incorporate the abdominal core surgery rehabilitation protocol and the ACHQC mobile app into my practice. And my practice name is Oregon Surgical Wellness. Okay. Oops, sorry. So I'm going to talk about three things: abdominal core surgery rehab, ACHQC mobile app, and also some patient information flyers that I usually give to my hernia patients, where there's inguinal hernia patients, ventral hernia, umbilical hernia, or abdominal wall reconstruction patients. So where to find this wonderful information? If we go to the ACHQC website, under patient information, under patients, you will find abdominal core surgery rehab. And if you click on there, the next page that it will bring to you is abdominal core surgery rehabilitation, a more detailed description of what you would benefit from using this, and self-care for healing and recovery, stretching, activities of daily living, and exercise. Now, I actually utilize this information by telling patients to go onto the ACHQC website to get the patient guide. And you will see this guide is 37 pages long. So I don't want to, you know, we are very green here in Oregon, so I don't want to kill any trees. So I direct them to the website in order for them to get the information. Some older patients, however, they don't actually have computers and stuff. So I would print those out for those patients. Now, I have been in collaboration with physical therapists, both inpatient and outpatient, and I actually have printed out or forwarded this information for physical therapist guide and inpatient guide for patient and physical therapist to hospital physical therapy department. So this is very, very helpful. This is how I initiate my collaboration with the hospital physical therapist and then also outpatient physical therapists who I can depend on to refer my patients to when after they have their surgeries or even before their surgeries. So when you click on the patient guide, I just want to show you, this is how it looked like, at least the first page. It's 37 pages long, and it's full of information and pictures of exercise and so forth. And then if you click on the abdominal core surgery rehab protocol physical therapist guide, it's about 15 pages, and I usually forward this to the physical therapist. And for the hospital inpatient guide, it looks like there's only 5 pages, but I also kind of borrow from the other 2 and sent this to the Department of Physical Therapy in the hospital. And I use Epic for my hospital. So this is my little pre-made click on Epic for PT evaluate and treat abdominal core surgery rehab protocol. So when I click and order this for my patient's post off, it's just one click for me, and they know exactly what they need to do for the patient. Now the app, I just can't believe how great this app is, because it's free for one thing. Somebody actually put this together and for patients or anyone to look at, to be able to kind of improve their core, abdominal core. And I give this out pretty freely, meaning I give it to all of my patients who are having hernias, because if you have one hernia, inguinal hernia, you most likely have a pretty weakened abdominal core. So I think anyone who are having hernia surgery should know about this. And this is where you find this Abdominal Core Health mobile app on the website, ACHQC website. And this is the next page after you click on it. So when patients go here, they can download to iPhone or Android. And I actually, if you want to share this with your colleagues, you can download a flyer for surgeons as well as flyers to patients, which is one of the flyers that I actually give to my patient. This is a flyer for surgeons if you want to share that with other surgeons who are doing hernia surgeries or just are interested in this type, even the physiatrists in your area, rehab doctors. And so when I see a hernia patient, after we talk about the surgery, after we do the normal H&P physical exam, then I inform them, go to my website, OregonSurgicalWellness.com. We actually have a hernia repair and robotic program. I do robotic hernia surgery as well. And I said, visit the website, read about this, and there is a click to on a link on our website to ACHQC. So this takes them to the ACHQC website where they can find all kinds of information that is useful. Especially I will point them to the patient information part. Another one flyer that I think is really, really important is talk about mesh. And everybody worries about the mesh, you know, all the lawsuits out there and so forth. Everybody asks you about mesh. And I said, at the end of the day, depending on the size of your hernia, most patients will require use of mesh. And by the way, it's endorsed by the American Hernia Society. And I actually hand them this piece of information. And by the time we go over this, most of them will say, okay, I understand what the purpose is for the mesh and you know, how important it is to incorporate that. So this was a something that was sent out by the AHS in 2018. I kept that. You can actually Google and find this, but the more recent, you can find information on this website link to patient education for AHS, and it's right here, AHS Mesh Advisory Statement. And if you click on there, here it is, and it's been updated. And so I always, you know, have both the paper form as well as the online form for the patients. Now, I also, because we are we are in the midst of this opioid crisis, I always say, I am not wanting my patients to take too much opioids because it causes constipation and it's gonna make everything hard because you're gonna feel bloated, and after hernia surgery, that's not what you want. So I actually print this as well as direct them to the website for the opioids reduction initiative to emphasize how important it is to take Tylenol, ibuprofen, and I'm just going to give you a prescription for inguinal hernias. I only give patients a prescription of 5 pills, and for bigger hernia, ventral hernia, usually about 10 pills. And that's all I give them is 10 pills of narcotics or 5 pills of narcotics. And also, this is the last flyer that I give to my patient, which is the free app. And I emphasize how wonderful this app is because there's videos associated with the app. And once they download this app, this is where they can go to the ACHQC site to download, or they can just find that on the app store, ACHQC, and they can download, and they can get helpful information and tips about how to prepare for surgery, learn to exercise with recovery from surgery. And there's also, for us, surgeon Oracle calculator to estimate the surgical risk. And this is just some of the screenshot. I'm sorry, I apologize for being a little blurry here. This is just screenshot on my phone that I sent to myself to put on a slide. That's why it's slightly blurry. But when you get onto the app, it's give information about before surgery, rehabilitation, and information about self-care, stretching, daily activity of daily ADLs and exercise, and then also on the day of surgery, reminder, exercise after the surgery, rehabilitation. How many of us have gotten questions about, oh, when can I do what? I'm like, okay, you can just go use the app. Here you go. Week 0 to 2, 2 to 4, 4 to 8, 8+. And of course, you'll give them advice according to, how big the hernia is. And but I find this very, very useful. And that's all I have for you today. I just been part of AHS since 2014, and I've been part of ACHQC for a long time. And I so appreciate the resources that we've been given to incorporate into my practice. And I do see quite a few patients who have hernia problems, and they are very, very impressed with especially the app. So that's all I have. Thank you.
Thank you.
Yeah, a great presentation full of practical information. It's one of the best parts of being involved in the QI committee is that I've been able to steal a lot of ideas from my fellow surgeons across the country, and certainly was able to incorporate these ideas into my practice. So thank you very much. Dr. Peterson?
Yeah, again, thank you, Dr. Henderson. Your commitment to incorporating all of this into your practice is really a fantastic model for us as well here in Kansas. So our next speaker is Dr. Rana Higgins, who's an associate professor at the Medical College of Wisconsin in Milwaukee. She's a minimally invasive and bariatric surgeon, and her hernia practice focuses on robotics and complex abdominal wall reconstruction. The title of her presentation today is The Utilization of Physical Therapy Among Hernia Repair Patients, a survey of the ACHQC. Thank you, Dr. Higgins.
Of course, and thanks for having me. Can you see my screen okay? Great. So just to give you a bit of a background, obviously, we're talking today about physical therapy and rehabilitation in hernia repair patients. This has been studied in many other fields, most commonly in orthopedic surgeries where you see it, but really in hernia repair patients, there's been a really stagnant advancement of physical conditioning and rehabilitation in this patient population. And in numerous other surgical specialties, physical therapy has demonstrated significant clinical benefit, but specifically in hernia repair, there's been minimal literature. In fact, one of the most recent publications was from Hernia in 2021, where the abdominal wall muscle was really compared to extremity muscle, in that abdominal wall muscle should be considered to have tendon function, and in terms of repair and rehabilitation should be considered as such as well. So when we perform an abdominal wall reconstruction, we should really be treating it similar to an extremity tendon reconstruction. So a lot is, it's certainly an evolving field, but there's definitely a paucity of literature about that. So as we all know, our focus of the ACHQC is abdominal core health. And so as a committee, we really became interested in the utilization of physical therapy in hernia repair patients across the QC. So as Winnie mentioned, the core rehabilitation protocol that you all saw that she went through so nicely was launched in 2019. It was designed by surgeons, physical therapists, and nurses. Really provides a great education resource for patients to help with strengthening and mobility, just as she showed you both before and after surgery. So as a committee, we decided to move forward with this survey to try to determine what is the utilization of physical therapy amongst our members in hernia repair patients. So we sent an email survey out to all of the members in March of 2021. It consisted of 11 questions. Essentially, the questions were focused on what is the current use of physical therapy in practice, and then what are surgeons' opinions on functionality, benefits, and barriers to the use of physical therapy in their hernia repair patients. So of all the members that we emailed, we got 46 respondents, so about a 10% response rate. So I'm going to go through the questions now. The first question we asked was, do you use physical therapy for your hernia repair patients? And you can see it was pretty split here, about 50-50. A little over 50% said yes, they do use physical therapy, and 48% did not use physical therapy. So then we wanted to really kind of get a sense of why this was happening. So what types of hernia repair patients are provided physical therapy? So amongst those who answered that they do provide physical therapy for their patients, you can see over 90% all chose abdominal wall reconstruction as the primary type of hernia patient for which they're providing physical therapy. You can see here open ventral or umbilical hernia repair, and then a ventral hernia repair with a rectus diastasis plication are also choices as well, around a little over 40%. And any sort of MIS hernia repair is a little bit lower, around 30%, kind of tied here with peristomal. But overwhelmingly, the vast majority of those surgeons who provide physical therapy to their patients are doing so for abdominal wall reconstruction. So then we were curious, well, what are the reasons for those who have not used physical therapy? Why are they not using it? So you saw that around 48% of respondents were not using physical therapy. So about half of those who responded said there was an unknown clinical benefit, which is really quite interesting and kind of ties into what I was saying earlier about the paucity of literature about the benefits of PT and hernia repair. But unknown clinical benefit was overwhelmingly one of the major reasons. And the two other really interesting responses were unknown physical therapy resources or unavailable physical therapy resources. So Winnie mentioned to you the collaboration that she has with physical therapy. So this was an interesting response as well, in that surgeons don't know of or do not have the available physical therapy resources they need. We also had other as an option. And so we wanted people to kind of give us some more qualitative answers for why they're not using physical therapy in their hernia patients. So we had several responses to this, but just to highlight some of them, one of the first responses was that it was not needed for small hernias. So one interesting thing this person said was, for abdominal wall reconstruction, the physical therapists do not understand the operation and start with too high a level in early post-op period. I think that's a really interesting comment and highlights the importance of really collaborating with physical therapy, and how Winnie had kind of mentioned sharing the protocol with physical therapy as opposed to just letting them work totally independently. I mean, communicating so that they know what you want, I think, is an important thing. Unnecessary cost and burden. Patient self-rehab, I'm not sure that's totally true. You'd hope that they would self-rehab, but certainly I think there's a lot of question as to whether or not that's happening. The cost and burden is interesting, you know, what that cost is and what that burden is, especially if it's inpatient physical therapy. You know, it's typically rolled into the operative package. So I'm not sure what cost they're referring to specifically. And then this one was also interesting, saying it's very difficult to make that happen. And I'm assuming that kind of ties into the idea of that issue with collaborating with physical therapy, which is what may contribute to the difficulty. So another question we had was the timing in which physical therapy is used. So you can see no one exclusively used physical therapy as a prehabilitation before surgery. They either used it after alone, or they used both before and after. So the vast majority just used physical therapy after, or before and after. None exclusively used it before, which I think makes a lot of sense. And in what setting do you use physical therapy for your hernia patients? You can see inpatient, almost 40%, outpatient, 30%, and a good cohort of people use it both inpatient and outpatient. So good to show that, you know, what the distribution of that is in terms of when surgeons are using physical therapy for their patients. How often are you using physical therapy in your practice? 40% said sometimes. Around 30% said both often and rarely, and a smaller cohort said never. So this was amongst those who are using physical therapy. It's most commonly used sometimes and often, but still over almost 30% are using it rarely. So the question is, why is that? Now, I mentioned at the beginning that just over 50% of surgeons who responded used physical therapy in their hernia repair patients. Interestingly, over 70% actually perceive a benefit of physical therapy in hernia repair patients. So even though over 70% perceive a benefit, only 50% are actually using it. So another interesting thing to explore why the discrepancy. When we asked what do you think are the benefits of physical therapy, we got a whole range of responses. Here's just a sample of them. So increasing core stability, increasing range of motion, increased mobility, increased core strength, less complications, better quality of life. So all things that we can obviously assume and have definitely been proven in other areas of the literature, really emphasizes why physical therapy is so important, and why I think a lot of the surgeons responded that they think it is beneficial, even though they may not themselves use it. So we categorize these qualitative responses into categories, and you can see recovery, core strength, and mobility are the top three, but you can see pain, ADLs, education, quality of life. These are all responses that we got in regard to that question about the benefits, but the biggest thing is recovery, core strength, and mobility. That was what we found that surgeons really identified were the benefits of physical therapy. Now on to what Winnie was talking about, the ACHQC abdominal core surgery rehabilitation protocol. Only 30% of respondents use the actual protocol and about 70% do not. So again, really highlighting that there is a gap here in terms of potentially what resources they know that are available out there for them in the QC. When we asked, why have you not used the protocol? A third said they didn't know about it. A third said there was an unknown benefit. Not really many people thought it was too long. And then when we asked for other responses, this is again a sample of what we got. So far more extensive than most of my patients need pre-op. I use my own, lack of time and effort, no partner from physical therapy. Patients don't seem to need it, have not set up a protocol, use my own. So you can see there's a vast majority of responses here. But this part is interesting that a third didn't know about it. And then the question is, how do we address this, these other these other surgeons, these ones who perhaps use their own or don't feel that they have a collaboration from physical therapy. So for those who do use the rehabilitation protocol, we asked, how have you disseminated it? The vast majority, almost 70%, have downloaded it from the website. A small percentage use the app alone, and about a quarter use both the website and the phone app. So again, access to the app, I think, can certainly be improved, but you can see a lot are downloading it from the website. So overall, as I mentioned previously, 72% of surgeons surveyed do perceive a benefit of physical therapy in hernia repair patients. However, only 42% of them use it occasionally and 27% rarely. So not as frequently used, even though they do perceive a benefit. I talked about some of the perceived benefits: increased core strength, stability, mobility, increased patient satisfaction, education and independence, earlier return to work and activities of daily living, and overall improved recovery. Those were resounding throughout when asked what the benefits of physical therapy were. Some of the barriers, as you can see from these results, are a lack of education, the lack of evidence on clinical benefits, specifically in hernia repair patients, that's in the literature, and then a lack of physical therapy resources, depending on whether those are inpatient or outpatient. So obviously, as I talked about today, there's a high perceived benefit of physical therapy by surgeons for hernia repair patients, and surgeons are willing to adopt physical therapy and rehabilitation protocols. However, we need to continue working toward overcoming barriers of the lack of education and evidence regarding benefits of PT in hernia repair patients, and we need to improve education and dissemination of the ACHQC rehabilitation protocol, which is one of the purposes of today's session. So thank you all so much, and we'll take any questions.
I think that we're going to have a question and answer period after, if that's all right with everybody else. Rana, thank you for doing that. That's really well done analysis of some complex issues that we'd all been talking about. So thank you. Lots of things there to think about.
And I will introduce our final speaker tonight to wrap things up. Of course, Dr. Ben Poulose from Wexner Medical Center at The Ohio State University. Of course, he's professor of surgery there and co-founder of the QC. Tonight, he will present on the pilot trial of abdominal core rehabilitation to improve outcomes after ventral hernia repair, the ABventure P study. Dr. Poulose.
Great, thanks everybody. Thanks, Ron and Ragnar. This is actually, I think this is going to be one of the most useful sessions, especially as we learn more about how core surgery rehab is really going to help our patients. These are my disclosures. So as Ron mentioned, I'm going to talk a little bit about the ABventure P study and just a little bit of background. So about 13, 14 years ago, when I was kind of entering academics after training, one of the things I was interested in was seeing whether or not we could ever obtain any federal funding for hernia research. And boy, I must have put together 9, 10, maybe 11 grant proposals during the first 4 or 5 years of my practice. And pretty much the universal response I got was, this has all been figured out. And literally I can still, have the responses in my mind. One response I got from this study section that reviewed one of the proposals I put from the NIH was, why did you even submit this? You can just do component separation for everything and it's all okay. And, obviously those kind of answers were kind of reflective of the state of what the National Institutes of Health, I think, thought about funding for hernia surgery. And this is important because what's reflected in funding is really reflective of the importance of what people perceive as important things to investigate. And so as most everyone who's done any kind of academic work in the hernia space, we pretty much resort to, obtain funding from a lot of our industry partners who have a lot of clinical questions that need answered. clinical questions we need answered. And so often we partner with industry, which largely funds our research efforts and certainly helps fund the QC as well. And we're very thankful for that. And so last year, we get a little bit of more background about how this all came about. When I moved to Ohio State, one of the really cool things about our institution is that, as everyone knows, we have the best football program in the country. Thank you very much. I think we're up to number 6 now. And that's right. Any Alabama fans out there? Sorry about that. But one of the cool things about having a really strong athletic program here is that we have a really progressive and very forward-thinking group of physical therapists and occupational therapists. And it was something that didn't dawn on me until last year. And as many of the speakers have mentioned, the abdominal core surgery rehabilitation protocol that we use in the QC took about 4 years to develop between some of the time at Vanderbilt I was there, and then also a lot of people contributed over the past couple of years here at Ohio State, the clinic, Prisma Health, and a couple of other institutions. And so what we thought we would do last year is, as many have mentioned, we don't really know the clinical benefit yet of targeted core physical therapy in the hernia space. As Rana mentioned, we suspect there's a pretty good benefit for it, and there's some initial data that's again just sporadic, but not very convincing or very high level. And so myself and two physical therapists here at Ohio State, we put together this proposal really during COVID times when everyone was kind of scaling back on things. We're like, hey, let's just put together this NIH grant, and we submitted it, and it got funded. It was just blew us out of the water. I mean, it was one of those things, and it was funded on the first try. And in fact, one of the things that really struck the study section was the intersection between abdominal core health, that whole kind of paradigm, and also using physical therapy as a way to help our patients in some of the most mobile areas and dynamic areas of the body that we just kind of sort of ignored in terms of its role with physical therapy. So this is a registry-based pilot randomized controlled trial. We got just under $1 million to do this. It's a study embedded within the QC. And so I just also want to note, especially to our some of our foundation partners on this call, and also George is here from the FDA. To me, this is the real power of the QC. This is one thing that was recognized by the study section, that, hey, you're using a data collection mechanism from surgeons that are not only in academic centers, surgeons largely in private practice as well. This is really, truly real world data, and it's allowing you to do something cool by embedding a randomized controlled trial within the QC itself. And this was funded by the NIDDK. We literally just found out about our funding about 2 weeks ago or so. This is our group, Steph DeSassi. She's a successfully funded PhD in PT. Ajit Chowdhury, also a PhD researcher. Ajit actually, he's devoted his entire academic career to core stability. I didn't even know that was a thing until I met him. And I'll show you one of the cool tests that he's developed to kind of test to see if there's something we can measure in terms of someone's core stability. Savannah Renshaw is our project coordinator. Many of you would know Savannah. She's fantastic, and she's helping leading this effort. Lai Wei is our biostatistician on the project. And again, this is our study team, and we're super excited about this. This is our core surgery rehabilitation page, and many of you have gone over this. The PT guide in terms of our abdominal core surgery rehabilitation, it's really detailed. If you haven't taken a look at it, it's worth taking a peek at it, because it's very regimented, and it's also flexible enough to allow individual patient variation, and it gets pretty detailed. This is a group that really came up with this core surgery rehabilitation protocol, both from the inpatient side, the post-operative patient instructions, and also the instructions for physical therapists. So in summary, here's a study. So basically, patients are randomized to either the ACHQC Rehab protocol or standard post-op instructions. I think most of us are familiar with the standard instructions. Again, this group is probably more progressive here, but the standard post-op instructions after hernia repair in general are pretty weak. In fact, we have historically erred on the side of having patients not move, thinking that this would somehow disrupt the repair or cause issues with the stability of whatever hernia operation we're talking about. And it's interesting, I think Rana mentioned this about the parallel between tendon repair. And that's really important because when we first kind of came up with this idea of the rehab protocol about 4 or 5 years ago, we were looking for what is the evidence in terms of collagen-based repairs, that when can you actually start doing aggressive physical therapy. The group that has the most evidence with this really is in tendon repair, and it's our hand surgeons. They've looked at this in quite detail. And what they found is that after about 3 days, assuming you have a technically sound operation, collagen cross-linking occurs in a pretty reasonable fashion that you can begin pretty aggressive physical therapy. So we've kind of extrapolated from that, this idea that we should probably be doing some of these physical therapy or core exercises much, much earlier than we've traditionally allowed patients to do physical activity. Everyone knows when we were training, a lot of the instructions we gave or our attendings gave to patients was to wait 6 to 8 weeks, don't lift anything heavier than 5 pounds. I mean, that's like every instruction's ingrained in people's heads across the world. And I think this whole exercise, this whole session, and what we're doing is really challenging that based on some data. And so patients are randomized to either the rehab protocol or standard post-op instructions. They're given 2 assessments at 10 weeks and at 1 year. These are adult elective ventral hernia repair patients. And notably, the transverse hernia width should be 2 centimeters or greater. And we picked that because we wanted to kind of filter out the umbilical hernia patients mostly. And then we do PT assessments and then a couple of quality of life scores, which I'll kind of show you about. So these are the outcome measures. And the primary outcome measure is what's called the 5 times sit to stand. And I'll show you what that looks like. And also the PROMIS physical function assessment at 10 weeks. Secondary measures include something called a quiet unstable sitting test. And this is the core stability test that Dr. Chowdhury had developed, and also the 1-year Hercules and recurrence assessments that we all know in the QC. This is the 5 times sit to stand. So basically, a subject or a patient sits on a chair and literally sits and stands 5 times. You're not supposed to touch your back to the chair. And you want to reach maximal extension with standing, and you want to sit in a resting position. And then after the 5th time is done, you remain seated and the timing ends. Here you can see most people hover between 20 and 25 seconds. We've done some pilot work with the 5 times sit to stand. It's quite impressive. There's actually a fair amount of variability from patient to patient, and even hernia patients and non-hernia patients. So it's kind of a, for lack of better terminology, a holistic way of seeing if everything is coordinated and works together. This goes back to the concept of abdominal core health, where the anterior abdominal wall is related to the back, is related to the diaphragm, is related to the pelvic floor. And these are kind of these full body, full core functional assessments that our physical therapy colleagues are well familiar with and integrated in their practice. But we as surgeons, especially those of us, focusing on the anterior abdominal wall, we don't think of these things as ways of measuring the success of our operations. So this is me in clinic. That's not me doing yoga. That's not me doing yoga. That's me doing the Quest, the quiet unstable sitting test. And so this is a half Bosu ball with a force plate, and that's my center of pressure right there. You have to close your eyes for 2 minutes and stabilize yourself with your arms crossed like this. It's hard to do for 2 minutes. I'll spare you what happens at 2 minutes here. But what happened was I started swaying. And what we measure is we can actually measure where that little dot moves in terms of this force plate. And we looked at this in hernia patients and in patients without hernias. We actually got patients' family members to sit on this who didn't have any hernias. And we found a pretty big difference. You were able to discriminate people's core stability, even symptomatic inguinal hernias. We were able to kind of differentiate from folks who didn't have a hernia disease. So this is really kind of a fascinating test. And this is our timeline. It's a 3-year study. And it's a 4-year study. And here you can see it's kind of the initiation of physical therapy enrolling patients. We have a goal accrual of 94 patients. You notice that's a fairly small number for a randomized trial. That's intentional because the goal of this trial is not to really say anything definitive. It's a new mechanism that the NIH is putting out there as a way to develop some preliminary data in a pretty systematic way that then leads to a larger multi-center trial that our goal is to implement the QC with another grant across the collaborative across multiple sites. So really, this is the paradigm shift that enabled it. We got a lot of feedback from the NIH that this is exactly the idea that struck a chord, rang a bell with many of the folks who are deciding on where funding goes in this country, NIH dollars. We all know there's a lot of funding for cancer. There's a lot of funding for transplant surgery. There's a lot of funding for trauma surgery. The reason why I firmly believe why we haven't had a lot of success in the hernia world, we never connected the dots for folks. We just kind of, put it out there that these are all simple problems. It's not an issue. Well, now we know these are chronic problems. We now know that there's probably a link between all these functions of the abdominal core. And you can see here, and this is Dr. Chowdhury came up with this, and this really kind of is the conceptual model of what we're talking about. So this is core function in the middle there, and that's the abdominal wall function that couples with lower back function, diaphragm, and the pelvic floor. And these all work together for all of us to perform our activities of daily living, and there are multiple ways of measuring that. So this whole kind of paradigm, I think, was a brilliant way, again, credit goes to Dr. Chowdhury, of putting this all together, especially from folks who are interested in funding these type of things. And so a couple of firsts here. This is the first federal grant using the abdominal core health paradigm. And I think what we should be really proud of, all of us, is that this is the first NIH grant supporting a clinical trial in ventral hernia. To me, that's a big deal, because what this represents is that for folks who are just coming up the ranks, coming out of training or junior faculty, now you have an in terms of really making an impact with federal dollars, because this also signifies that this is a significant shift of what the NIH thinks is important. And I will also mention, I know we have George on the call here, and FDA also is paying attention to this in terms of the importance of paying attention to hernia as a public health problem that needs funding to help make patients better. And I think there's no better way for us to demonstrate this than getting federal funding and also having support, not only from our foundation partners, from our FDA colleagues in making these type of things happen. So I'll stop there. And again, I think it's something that we can all be proud of, because I think without this type of funding and this type of mechanism and collaboration, we get kind of stuck in terms of our field. You can only imagine if there was no federal funding for transplant surgery, for cancer. I mean, where would we be? We would not be far at all. And I think, again, this is something that we can look forward to. And I really hope some of our junior partners and the young faculty members take advantage of this time, because I think the time is right for this type of funding in hernia surgery. So thank you.
Congratulations, Ben. That's a great accomplishment to you and your team. Really look forward to reading about that and learning more as we go. That's really cool. So at this point, those are all of our presentations. I think we would open it up to questions if any of the callers have anything they'd like to ask any of our panelists. Any other comments?
Hey guys, I'll jump on and say a couple things. I first of all, those were phenomenal presentations, and I think the thing that kind of strikes me the most about all of that, and I agree with Ben. When you think about these things, you never really know what direction you're going to go, and then all of a sudden you kind of hear this, and you're like, wow, like this is great. We need to go here. And I think one of the biggest things, and I think Rana kind of mentioned that, is it's the inertia of like, how do you do this? It's the same thing of like, how do you incorporate the QC in your practice? And so for those folks, at our place right now, it's hard enough to get a nurse to see a patient on the floor, much less, getting physical therapy. So kind of just some like practical pointers of like, how did you actually do it for the inpatient in particular? You know, setting this up, one, and then my other one is for outpatient physical therapy. I think Winnie, you spoke about this. Any issues with insurance, getting that covered? If you write that order, do you get any pushback and any kind of problem solving things around that?
So for some reason where we're at, I never get any pushback if I say core and back injury prevention. I put that little tidbit on the end of it. We've never gotten any pushback on it, but that could just be a local regional phenomenon.
So far, I have not had any pushback. You know, a lot of the insurance company is really into preventative measures these days. So a lot of companies are actually covering physical therapy, which we may not be aware of. Of course, inpatient is the easiest because they're inpatient. And the way I started with our program here is that I first get the buy-in from the manager of the physical therapy department. And we, you know, had a discussion, we exchanged notes, we did a presentation to the physical therapist, we've got the buy-in. And that's why I'm able to literally just click on an order, and then my patients get you know, the physical therapy evaluation right away. One other thing is that the patient, if they did not did not bring the app or the book or whatever, the physical therapist actually have them, was able to bring them up. So it makes it easier. But no, I have not had a lot of pushback from outpatient physical therapy. I actually have a couple of companies here in Springfield, Eugene area that are very interested in participating. I mean, the more business for them, and actually insurance companies catching on. And with, you know, grant funding like this, that's actually more impetus for them to, you know, pay attention to this.
Yeah, so I've consistently billed for trunk weakness, especially in the post-operative phase, or put in the consultation trunk weakness. And our physical therapy group hasn't really had an issue with that. The main thing that we've had some struggles with is just the timing of getting folks in for the post-op physical therapy as an outpatient. Because if you look at that protocol, there's some pretty specific windows, and coupling that has been a little bit of an issue. We finally have kind of gotten into an area where we can see someone post-op, make sure their wound's okay and things are pretty stable, and then get them into physical therapy pretty quickly, as opposed to waiting 6 weeks. That was one of the big issues we faced. For the inpatient stuff, it's probably the most underutilized part of this protocol is the inpatient exercises. And I actually, my own bias, it's probably one of the most important components of this. But what we're seeing happening is that most physical therapists will kind of do their own thing. And, you know, the physical therapy that we all order, what we see, what we kind of think is happening most of the time is, you know, a PT just picks up a patient, walks them down the hall and does so, you know, that's really not physical therapy. I mean, that's just walking someone down the hall. And so what the education piece we had to kind of put into that, at least here at Ohio State, was, hey, you can do more with patients as PTs than just walk them down the hall. Now, if you go back to the tendon repair data I quoted, that's really 2 and 3 days. So if you think about it, if someone's staying only a couple of days, probably not much time to do this. But if someone does stay longer, you know, or more complex repairs, then I think there's an opportunity to do a little bit more.
And if the patient's able to see physical therapy in the hospital, it reinforces the idea to them that they may need to, say, look at the app to see if they, you know, can keep up with the app. If they can, sometimes I will get a phone call that they would like a referral to a physical therapy outpatient, and that kind of carries that whole program on, a protocol onwards. I usually see my patients 4 weeks post-op, and this is something that is actually because, you know, private practice is so busy sometimes. And I actually seen them at 4 weeks post-op. So right there, I have actually one of the 30 days endpoint for my, say, SSR, ACHQC, data. So I'm not worried about 2 weeks because they actually would just call if they have problem.
Great. There's one question here in the chat. It's what are the main outcomes you're looking at the study? Right. So we're looking at some very specific PT related outcomes at 10 weeks and 1 year. And that is the 5 times sit to stand, and also the QUEST, the quiet unstable sitting test, which is one of the core stability tests we're evaluating to see if that can help differentiate and see how people do between the physical therapy and the kind of the standard instructions. And then we're also giving folks the usual QC quality of life measures, and we added on another PROMIS kind of health status functional measure as well. So really it's a whole battery of stuff, but the thing that we added mostly was the physical therapy assessments. It's funny, I tell you a funny story. So when I was giving some initial talks to the physical therapy group here at Ohio State, and they're like super engaged in terms of, talking about the oblique musculature and our physical therapy colleagues place such high importance on transversus abdominis muscle activation in terms of core stability, breathing, and things like that. I told them, look, I just like beat the crap out of the transverse abdominis muscle like 5 times this week, and my patient seems to be breathing okay. Like literally they all like gasp. And it's like, oh my God, like, you're like cutting this muscle, like what's happening? It's kind of interesting, both from their standpoint and how much, the transverse abdominis is like this hallowed thing. And from our standpoint that here we are just like beating it up and patients tend to do okay. So I wonder if we are doing some more harm than we think. I don't know. Mike's looked at this.
Well, I mean, I was going to ask you, that was my other question. Don's got his hand up, but I just real quick, I would just say, I was curious if some of those things you were doing, like the 5-minute sit to stand and the QUEST thing, if you looked at particularly some of these people with some of these more advanced releases, and in particular in the people who were kind of younger, healthier, and a little bit more functional, because I actually do think that there is a price to be paid for cutting that muscle. I've been giving talks in front of physical therapists and people, and they are horrified when you cut that muscle. My only kind of thought on it, because we don't necessarily see it, but this might take 10 to 15 years to show up, is that we're cutting the insertion, not the origin. And I think that insertion might reinsert, if you're putting mesh there, but I mean, that's all theoretical, but I think some of your work would be really cool to look at different operations and see how that might affect some of the core stability, because as we get more and more advanced in the releases that we do for more and more routine hernias, some of these things might show up that, if you fix a 30-centimeter hernia, your front is so bad, maybe you make your back a little better. But if you do that for a 6 or 7-centimeter hernia, the advantage of the front might not outweigh the core instability and whatnot. So I think it's unknown, but this is the stuff. But Don, you go ahead.
Yeah, maybe not the best question to ask toward the end here, but I have questions that revolve around cost and culture. So everybody that gets a hernia repair expects to get 4 to 6 weeks off from work. So how are you ever going to change that? Number 2, cost of PT. Obviously, when it's inpatient, it's all into the DRG. So it's probably going unseen right now because it's so widely underutilized. But if every hernia repair requires PT, could that be something where your hospital comes back and says, hey, your direct costs are more because you're consulting PT on every single patient? And then as an outpatient, although insurance picks up a lot of it, they don't pick it up at all. And so how do you talk to your patients about copays when they have to pay a copay for every PT visit? What do you do to tell them this is key for you and it's a good investment for you? Not only, unfortunately, are you getting them back to work sooner, which is against what they want to do, but you are making them pay a little bit more out of their pocket to get back to work sooner.
I would say tongue in cheek, parenthetically, I tell them to save the money that they're spending on the cigarettes and spend it on PT instead. But no, your points are very well taken. The honest answer is I don't know. And I think one of the really essential things that we need to try to get to is maybe physical therapy is maximally beneficial for a small group. And I think our committee's vision for this project is a several phase process where we ultimately come up with some recommendations, maybe who benefits more than other people would, that would add an argument for appropriate reimbursement down the road. But that's all speculation. I'll let the other panelists jump in on that with their thoughts too.
So I think that depending on how important this issue is going to become in our society, how functional people need to be in order to perform the ADLs, I think there is room for getting some attention and getting better reimbursement. Get it, for the physical therapist, and getting insurance company to pay for it. I can give you like something that maybe is comparable. The other part of my practice is breast surgical oncology. We are able to get most patients covered for lymphedema physical therapy, because that is such a big, bad problem associated with breast surgery, breast cancer treatment. So just kind of comparing the two, I think there is room, for improvement. There's room for more coverage by insurance company. I think this is just the beginning. And I think that, it's going to take time, but I think the clinical trials, the NIH fundings, all of that kind of bring to our, frontal lobe how important this problem is. And I think the future is it's going to look a little bit different for physical therapy.
John, I think to your point about patients returning to work, I think the biggest thing is kind of what Ben was saying too, making sure that post-operative follow-up is soon after they're discharged from the hospital, because if you frame it to patients that it's this especially critical in these first several weeks to attend your physical therapy appointments and to be actively involved in your care, I think that would be a good way to kind of frame it to patients, and that from that perspective, because it's just like, thinking about the orthopedic literature, somebody gets a hip replacement. I mean, the physical therapy in those first several weeks is such a critical part of their recovery. So, I think it's absolutely still reasonable, even though they're returning to their ADLs. I'm also a bariatric surgeon, and we want them up and moving immediately after surgery. And I tell them to take 4 to 6 weeks off, not because they're going to be immobile and not being able to do their normal activities of daily living, but more so focusing on their recovery and their rehabilitation. So I think that's really kind of the way we need to frame it to our patients.
Yeah, Don, great question. It's interesting. The copay issue came up just practically, and also came up several times in the context of this trial that we just got funded. The thing about it is most patients didn't see it as much of a barrier. We actually kind of polled a few patients just because the copays are acceptable. They're not, exorbitant. The thing that was the most resistant in terms of patients approaching this was just the time involved, and the kind of the back and forth going to a physical therapy group. Because I think if anyone uses to any degree, physical therapy has to happen locally and somewhere accessible by a patient within about 10 minutes. Once you start getting past that, if it becomes a barrier to actually physically drive from 30 minutes down to, the OSU campus, it's just not going to work. And so that's really one of the biggest challenges, is enabling folks locally to do this with their local physical therapist.
Yeah, I would make one other comment to that, which I think is going to be interesting, Ben, particularly for your study. You know, we see a lot of people 1 year out from ab wall reconstruction whose CT scans look perfect, their physical exam looks perfect, and they have some pain somewhere. And I usually tell them, hey, it's probably scar tissue, just break it up, it'll get better. But you wonder if they had done physical therapy earlier on, just like any of us who've had orthopedic injuries, or I mean, I've had a couple knee surgeries. The difference between doing rehab and not doing rehab is months of recovery difference. So I think this might answer some of those questions for why some of those people are that way, and hopefully find a difference. That's awesome.
All right. Any other questions or comments? It's a good discussion. All right, Ron, do you have anything else to add?
No, I just want to thank all the presenters tonight. Certainly started off with some great practical tips, then went into what we know from the QC and some barriers to instituting physical therapy for abdominal core health. And then finally, a great presentation on where we can expect to be, 4 years from now with that information. I think this is really what our committee is looking to push forward. And I look forward to being a part of that and being able to do it. And certainly want to thank the participants tonight, this evening, and then just wrap it up with go Dogs.
A couple quick announcements. Before everybody gets off. First of all, thank you so much to the panel and the moderators. Again, another just awesome session. This will all be online if other people want to watch it. I would like to just kind of make a plug out there for, this is what the QC is all about. This is a group of folks, many folks in this with a very diverse background, from private practice to academics to NIH grants to taking care of patients. So get involved in these committees. There's a lot of them, and they really all are, they meet monthly, and they are changing the way we operate the QC. So this committee is a perfect example, and congratulations on what you guys have achieved. I think this is just the start. For QC Core Insights, next month, it will be a 1 hour session on kind of robotics and learning from some of our high performers on different types of approaches and techniques and tips and tricks in that. And then we'll wrap up the year with some of our embedded trials and getting some data kind of here first when some of these are just hot off the press to figure out what we found. And again, thanks to everybody. Aileen, thanks for always putting this together, and great session. And we'll see you guys next month. Take care.
Thanks, everybody. Have a good night.
Go Browns.